Where was I? All right. We're seeing, as I said, mentioned, a huge increase in the amount of complex genetic testing being done, including in human embryos. With that, there's higher resolution. There's a number of add-ons, but surrounding that higher resolution and the add-ons is a number of controversies. Are we keeping up? Are we able to give patients, do we have the knowledge to give patients the most informed decisions about the genetic testing that they're undertaking or that their embryos are undertaking? I just mentioned there was been a variety of headings. Gene editing, we just saw a scientist released from jail this year in China who did gene editing in CRISPR in embryos. And we're seeing a whole bunch of other headlines. These headlines aren't always correct, of course, but we know that the press will try to make the most of any situation. Although my talk today is predominantly about genetic testing of human embryos, I do want to have a quick overview of the assisted reproductive technology process. It's a multi-step process. It requires not only a number of complex procedures, it requires a number of different healthcare professionals to make it work. Okay, I cannot overstate the importance of good stimulation protocols and the embryology laboratory in producing good eggs and good embryos if you're going to do PGT, if you're going to do genetic testing of human embryos. So, as I mentioned, ART is a team event. Good training between all aspects of between the doctor, between the genetics lab, between the embryology lab, between the support staff, the nursing. Everybody has to coordinate to produce the best results in the embryology lab in order to be able to do good PGT. At one of this morning's talks, Dr. Sean O'Leary mentioned about that the second biggest predictor behind maternal age was the clinic choice. This is so true. You should not be doing PGT if you have poor embryology. I'll talk more about that. So in talking about that, if you want to do human genetic testing of human embryos, then you should be maintaining rigorous controls in your lab. Rigorous controls over the stimulation, the embryology. Every aspect of your laboratory should have rigorous KPIs kept about the clinician, about the embryologist, about the genetic scientist, individually as well as a team. This, I would say, it's got a bit skewed, but is, from my view, almost a minimum set of KPIs you should be having in your lab if you're doing PGT or if you want to do PGT. Dr. Sean O'Leary also mentioned Newcastle, Genea Newcastle. I used to work for Genea and did biopsies at the Newcastle clinic. One of the things that Genea always followed was rigorous training. Didn't matter you came in after 7 years experience as a senior clinical embryologist, you had to go through a training process. They made sure there was rigorous controls, rigorous quality control in the laboratory, and that's why they were achieving the high results. There have been, of course, some improvements in trends in ART over the years. We heard talks this morning from, I'm going to get the names wrong, I'm very sorry, but Doctors Li Huang and Li Timin Chao, is it? I hope I said it right, on stimulations. There is no one size fits all. We do see clinics where the clinicians are just doing one size fits all for stimulations. That doesn't work. If you want the best outcomes, you have to personalize the stimulation protocol for the patient. We're seeing more and more talking about, and we had some talks about that this morning, about the male infertility factor. Okay, it's an increasing number of infertility cases are thought to be due to male infertility, at least 50% maybe nowadays. Therefore, improvements in sperm selection and fertilization techniques can improve outcomes. The culture medias we all use, I know some of them are very good now, but none of them are the optimal for embryo culture and development. Okay, we can always improve. Now, while things like continuous culture, particularly with time-lapse, is improving, additives, we've seen a number of additives used, not always successfully. Antibiotics were tried and they proved to cause gene alterations. We've seen oviductal amino acids, that's helped. We're seeing a lot of success with low lactate medias. All these steps will help to improve by using the best culture medias. Greater use of time-lapse, so less embryo manipulation by using time-lapse. In addition, we also heard the talk this morning. I'm sorry, I don't know, can't remember your last name, but Jean, is it, from Vitrolife, who John from Vitrolife, who was talking about the IDA score. So the software. So we've got done. Oops, go back. The greater use of embryo evaluation tools. So using software and artificial intelligence to pick the best embryos, to choose the best embryo, predict the best embryos. We're seeing greater use of PGD for aneuploidy, but again, I reiterate that should only be in clinics that have good embryology, good stimulation protocols, good embryology, and are using validated PGD protocols. And vitrification. Well, we all know that vitrification was one of the biggest leaps forward in ART in the last 10 years. PGT itself, composed of basically two steps, the biopsy and the analysis. I don't want to spend a lot of time on this, but we've seen over the years, since I started over 20 years ago in PGT, we've seen the jump from a polar body and cleavage stage through the blastocyst stage with its increased number of cells, so increased number of DNA, more accuracy in the analysis, using a smaller proportion of the embryo, not taking steps descent from the fetus, and of course blastocysts vitrify or even freeze before that very well. Okay, so you'd have to think that blastocyst biopsy was probably the gold standard for PGT. And the way, of course, it's done, most people know, but I'll just run through it a bit. Usually you either make a small assisted hatchet hole on day 3 on the cleavage stage, or you can make the hole at the time just prior to the biopsy itself. And then either some tracheostomes are herniating or you make them herniate, and you can just cut off using a low-powered laser some of those cells and then use those cells in the analysis. I don't know if the next one will work. It's going to work. Most people have seen a blastocyst biopsy, but this only takes a few minutes. There's a couple of reasons why I show this. That's actually the inner cell mass there. And I know a lot of laboratories and a lot of clinics will say, oh, you should never biopsy near the inner cell mass. Well, we don't particularly make another hole if the herniated tracheotomy is near the inner cell mass. And in this case, they've zapped a couple of the weak cell junctions. They'll tease off this tracheotomy. You'll see the tracheotomy. You'll see the embryo doesn't look that great. See it? See the cells. Then you'll see the embryo 20 minutes later. It's already re-expanding. And this embryo, I know, this was about 17 years ago, went on to form a viable pregnancy. So it's a very easy process in the hands of good scientists. The PGT methods, well, they went through mammoth changes over the years, as we're quite aware. From the early fish, when you sat there for hours burning your eyes out, through qPCR, array CGH for a long time there, SNP arrays. Of course, SNP arrays are still used, and the whole genome amplification, next generation sequencing is probably the method of choice. I'm not going to go through all their pros and cons, their limitations and advantages here, but the short answer is that you would have to, I think the general consensus is blastocyst biopsy and WG-NGS are the gold standards for the majority of PGD analysis. So why is genetic testing of embryos important? If it's used appropriately, as I've said, in an appropriate lab with validated protocols, it can increase the rate of implantation and therefore a successful embryo transfer. it will reduce the number of futile embryos, the number of embryo transfers that are not going to lead to a pregnancy, and increase the likelihood of a child born without a genetic disorder. In my view, there are two main types, and Professor Samuel Chang, who's going to give a talk on PGT-SR, may not agree with me, but that's PGT-M, so the pre-implantation genetic testing for monogenic disorders, and the PGT-A for the pre-implantation genetic testing for aneuploidy. PGT-SR, in my view, is in most cases a combination of those. PGT-M itself, of course, uses not only WGA-NGS, it uses SNP and fragment analysis on some occasions. I want to reiterate another point, two main points in the whole talk. One is you should not be doing PGT if you haven't got good stimulations and good embryology. And the second is realize that PGT does not alter embryos. PGT is purely a selection. It's purely selecting on the basis of genetic variants the embryo already has. So PGT-M, I'll discuss that first because in some ways it's the least controversial. That is, there's many countries that won't allow it, so it's not controversial because it's just not allowed. But in those countries that do allow it, the many countries that do allow it, you can virtually use it for any monogenic disorder, and including, of course, HLA matching, as I'll discuss later. So as long as you know a known pathogenic familial variant then you can do PGT-M for monogenic disorders for a cohort of embryos from that couple. Expanded carrier screening recently, of course, has seen an increase in PGT-M. The more and more people that are having carrier screening is revealing more familial genetic variants, and we're seeing an increase in the amount of PGT-M patients. The other area, of course, is that simpler universal workflows have led to a reduction in text complexity. I say that they're actually probably more complex, but the software and the analysis software has made them less complex, if you like, easier to interpret. Along with that, they come with less time to either do the workups or even to do the clinical itself, and cost less. This has enabled PGT-M to become available to more clinics and therefore more patients. Right line. They also allow you to do PGT-A and PGT-M from a single biopsy in a single analysis. So at our clinic, for instance, we don't offer PGT-M, we offer PGT-M/A down here. Okay, and as I mentioned before, most common methods is NGS, but there are some SNP and fragment analysis done as well. So PGT-M for HLA matching, I have to put this slide in because as a clinic, we're quite famous for this, and we've done a lot of successful cases. In fact, our first 16 couples who had HLA matching have all had the stem cell therapy and 100% cure. So it's very beneficial. So what is it? It's if you have a child affected by certain disorders, both genetic and non-genetic, and that disorder is treatable by stem cell therapy, you can identify an embryo that's not only free of the genetic disorder, if it is a genetic disorder, but is also an exact HLA match to the existing child. Collect the cord blood at birth, harvest the stem cells, and use that to treat the existing child. And as I said, because it's 100% genetic match across the whole HLA region, the 4 or 5, maybe up to 6 megabases of the HLA region, it's very, very successful. PGT-A, okay, we're all aware, and as it was mentioned in some talks this morning, that aneuploidy is the main cause of abnormal embryo development, failed implantation, and recurrent miscarriage. And we've seen these graphs before. And the first one, this is trisomy in clinical pregnancies versus maternal age. And this one's aneuploidy in embryos versus maternal age. And they're almost mirror images, of course, of each other, showing that aneuploidy in the embryos and therefore trisomy in the pregnancies increases rapidly with advancing maternal age, meaning that over 35 and certainly in your late 30s and early 40s, it becomes quite difficult for a woman to have a viable pregnancy and a viable live birth. In theory, therefore, by selecting euploid embryos, you should be able to increase implantation rates, increase viable pregnancies, and increase live birth rates. So in that case, why is PGT-A controversial? And it is controversial. I would say there was two main controversies. The first around the fact that, as I mentioned before, PGT does not change embryos. Therefore, if you have, say, a cohort of 10 embryos and 5 are euploid, those 5 are euploid whether you do PGT-A or not. If you transfer those whole 10 embryos, you'll get the same cumulative pregnancy rate as if you only chose the euploids and transferred them back. Okay? So, for a lot of people, they see PGT-A as just an expensive add-on, right? A way of clinics making more money. However, I would argue that's not the case. A clinic that does PGT-A, so of course I'm going to argue that's not the case. PGT can reduce, and I'll show you some data in a minute, reduce the time to pregnancy by prioritizing embryo transfer, and it can reduce the rates of miscarriage. And this, you cannot underestimate, of course, the associated financial, emotional, and physical costs of miscarriage, or of having, of course, a baby who was born with a genetic disorder such as Down syndrome, or having to have an abortion because that's detected during the pregnancy. The second controversy, I keep on harping back to this, surrounds the fact that there's many clinics with poor embryology and poor stimulation or poor stimulations who are doing PGT. And in those cases, they're actually getting worse outcomes with PGT than they are with their normal IVF. That's because they have poor embryos and the biopsy process is putting more stress, I can't think of the right word, putting more stress on those embryos and leading to worse outcomes rather than better outcomes. However, as I said, hand in glove with doing PGT should be good stimulations and good embryology, and until you've got that, don't do PGT. And that's basically what the bottom of the slide says. I want to discuss two studies. My talk's not a lot of data. There's several talks following this and several talks this morning that will have a lot of data on various aspects of PGT, and so I'll leave it for them to do. The first one I want to do is a prospective multi-center study where every usable embryo was biopsied, but the actual analysis wasn't done. They transferred the single best morphological embryo in each case, and then they waited till the clinical outcomes were finished, and then they did the PGT. And what they found was that in 100% of cases where the embryo was labeled aneuploid after the PGT, there was not one live birth. Whereas in, nearly 65% of embryos that were labeled euploid, there was a live birth. Okay, I think this reflects the safety and benefits in deselecting aneuploidy embryos using PGT. The second study was a retrospective study out of Professor Semra Kamraman's lab in the Memorial Hospital in Istanbul. And this is a pre-publication, so I have to thank her for this information. In this case, women of poor prognosis, and you can see a list of the known poor prognosis reasons. So poor prognosis women, about 2064 women had a single good embryo transferred. 1,126 of them euploid embryos after PGT-A and 938 with no PGT-A. And as you can see the results over here, what happened was in the PGT-A group, you had around a 51% live birth rate, and in the non-PGT-A group, you only had a 29%, almost a double. Once you had selected a euploid embryo, you almost doubled the live birth rate. Again, I think this is, I think I've got a second slide on this. Oh, no. Oh, yes, I have. That in the presence of you can read it for yourself, in the presence of a single blastocyst, PGT-A increased the clinical pregnancy and live birth rates, and that was regardless of age. By the way, those women were from 24 to 40 years old. And after a euploid embryo was found, the live birth rate per embryo transfer almost doubled compared to a single embryo transfer without PGT-A. So it also decreased the number of futile transfers. But, of course, you have to counsel patients, particularly in the older age bracket, that they may, if they're going to do the PGT, they may have their FET cycle cancelled because there's not a suitable embryo for transfer. In summary then, I believe the PGT-A is a useful tool for the deselection of aneuploidy embryos, increasing clinical pregnancy and live birth rates while decreasing failed implantations and the number of futile transfers. Where it's used in an excellent laboratory using proven, validated protocols. Okay? I'll just briefly discuss mosaicism, so that's a topic of that, along with non-invasive PGT, is probably the two topics most discussed at conferences at the moment. Mosaicism is where you have more than one cell population in the same embryo but with different genotypes, okay? And that's called mosaicism. It's always existed. It's just now that with the high resolution NGS and everything, we're able to start detecting this mosaicism. It's independent of maternal age, and it also is independent of embryo development stage, albeit it does decrease from cleavage stage to blastocyst stage. The problem, of course, is the mosaicism is problematic. It's a problem in interpreting PGT. This study, please ignore the dart. I only realized in the last couple of days I failed to complete this, and it's wrong. That's close to right. There was actually 1,741 transfers, embryo transfers of mosaic embryos. And what happened compared to in the clinics in this study, compared to the euploid rate of about 51% live birth rate, the mosaic embryos had a 36.8% live birth rate, pregnancy rate. That if you divided the mosaic embryos into subsets, then you found that those with whole chromosome mosaicism only had about a 31% live birth rate, and those with partial chromosome mosaicism had about a 41%. What it tells us is that, well, one of the things in that study was it was shown that there was a cutoff of around 50%. So if the mosaicism was higher than 50%, outcomes were very poor. If the mosaicism was less than 50%, then the outcomes were quite good. Also, low mosaicism, as you might expect, low mosaicism was better than high mosaicism. So if you had a mosaicism of 15, 20%, that was better than 30, 40, or 50%. And while euploid embryos are significantly more favorable, mosaic embryos can result in healthy babies, and the evidence supports that they should not be discarded. But it's interpreting these mosaics. I would suggest that you have to have consistent data-driven guidelines for doing this. And right now, I would suggest that the PGDIS guidelines are probably the best and easiest to follow. Segmental aneuploidy, so that's where only a small part of the chromosome is aneuploid, trisomy or monosomy. There's very little data on transfer of these embryos, but the data would suggest they're very risky to transfer. That is, they do lead to very poor outcomes, either miscarriages or live births with abnormalities. Okay, and while the data is very limited right now, I would strongly suggest they are too risky to transfer. And I'll just leave segmental aneuploidy at that. Oh, the other big topic, as I mentioned before, is non-invasive PGT-A. There is another talk in one of the sessions by somebody, I can't remember who, on non-invasive PGT, and you probably can hear more about that in their talk. However, it's been around since 2016, talking about using spent culture medium, so the culture media that the embryo is grown in, or even using blastocele cavity, but I don't see how that's an advantage, because one of the advantages is supposed to be that you don't harm the embryo by doing a biopsy. And I can't imagine that injecting and trying to take blastocele cavity fluid is much better than biopsy. However, it's mostly now, of course, centered around using spent culture medium. And they've tried all sorts of times and differences and stuff. But still, you analyzing the cell-free DNA, you would have to say, if I move on. Oh, sorry. The other reason that they say it's good is the mosaicism. Because in this case, you should be getting an average of the whole thing. You're not just taking a few cells where you might have some mosaic cells. You're going to get an average of the DNA for the whole embryo. However, the concordance between clinics is very poor. Even in the best clinics, they're probably only getting 80-85% concordance in the non-invasive PGT. There is one lab that continually talks about having higher in the 90s, but that's not been reproduced in other clinics and other laboratories. And you can see some results down the bottom with different centers. Why is it? I mean, they haven't worked out. I mean, there's contamination. What's the best time for collection? They've been finding that maybe day 6 and day 7 is much better than day 5. But then that stops your advantage of getting an embryo transfer, a fresh embryo transfer. There's still a lot of variation in the methodologies used. Nothing is accurate. And in fact, there's a class action suite against Monash IVF in Australia by older women who say they were falsely given advice on non-invasive embryo testing, and that false negatives, the false negative rate was so high, and many of their embryos were thrown away because the embryos were labeled as affected when in fact they weren't affected. Okay, so we have to be very careful when we use any new procedure, new add-on in PGT, that it's thoroughly validated and that the patient gets a full explanation of the genetics and the risk factors before they proceed. Predictive PGT. This was some very big marketing for this about 3 years ago, 2-3 years ago. This is where we use polygenic risk score. So looking at basically lots of SNPs across the whole genome and linking those to complex traits, such as certain types of cancers, as you can see here, heart conditions, as well as non-medical conditions such as height, cognitive ability, etc. Okay. It hasn't really caught on because it is extremely controversial. The actual level, while we're looking at genome-wide studies and doing this prediction, in the end, you're actually only looking at a family. When you do a cohort of embryos, you're looking at the family, and that's a very low difference. And therefore, to use this to select embryos, it's probably not useful. If you're going to use it for just to order the embryos, to say, okay, this embryo is likely to be the tallest, and this embryo is likely to be the shortest, okay, that opens up a plethora of ethical issues and controversy. Little gain for a lot of controversy. It also requires complex counseling of patients. Can you imagine trying to you look at 4 different complex traits? And then you're saying, okay, so this embryo is best for this one, but this embryo is best for this one, and this embryo is best for this one. Which embryo do you select? It's going to be. If we cannot currently agree on mosaicism, we're not going to agree on PGTP. Whole genome sequencing. When do we want it? Do we want it now? I think, in the future we will have whole genome sequencing of embryos, but that opens up a whole bunch. Maybe have very good reasons for using it. Maybe it'll be able to detect. Why do 30-odd% or more in most laboratories, but even the good laboratories, 30%, 35, 40% of euploid embryos not implant? Is it reasons in the embryo? Are we able to detect by doing whole genome sequencing that euploid embryo will not form an implantation, will not form a viable pregnancy? Will it reveal variants relevant to the embryo? Of course. Of course it's going to. It's whole genome amplification of the embryo. So it's bound to, but will it detect? How will that influence parental health? Are we going to find things? People may want to think, oh, great idea, let's test and put back a healthy embryo. Oh, then we find out, oh, you're going to die when you're 50 because you've got this, we just found it in the embryo. Do people really want that information? Do we make people say, well, if you're not willing to have full carrier screening first, then we're not going to do it on your embryos. It opens up a whole bunch of information that we may not be equipped to handle. Okay? Are we equipped to handle? Are we equipped to counsel patients on the information we would find from whole genome sequencing? In fact, as I said here, would no embryo be normal? And that applies, of course, to the predictive testing as well. Would no embryo be normal? What people want. This was a blog on whole genome sequencing in 2015 suggesting that it would soon be in. Well, it's not. Or is it? There is one laboratory that is advertising whole genome sequencing of embryos, but if you actually call them up and try to do it, you find that you go onto a waiting list. They're not actually providing it at the moment, but they will soon. Okay, just to summarize, that's the end. I cannot overstate how important it is to align to good practice standards across the whole assisted reproductive technology program, not just the PGD. The stimulation, the embryology, the biopsy, the reporting, the counseling, the whole box and dice should be first class, coordinated, a total team approach, cross-training, cross-collaboration. I think PGTM it has a clear application for selecting embryos free of inherited genetic disorders and or HLA matching. And I believe that PGT is a useful tool in clinical for increasing clinical pregnancy and live birth rates. But not all PGTA is equal. Please use appropriately validated PGTA tools. Mosaicism, make data-driven decisions about mosaicism. They're usable, but we have to make proper decisions on them and properly counsel patients. Question laboratories with, I'd say, greater than 10% mosaicism. You should not be getting greater than 10% embryo mosaicism. I firmly believe, and there's a lot of evidence that I haven't produced, but they're out there, that it's only poorer laboratories, poorer embryology laboratories, or poor stimulation protocols that are getting higher than that amount of mosaicism in their embryos. Question the accuracy of NIPGTA. I would say I would certainly deter my use. It's certainly not useful if you have to have the genetic decision. So it may have some useful use in screening embryos and giving an order of embryos to be put back. And of course, be cautious with any other add-ons, PGDP, WGS. I put mitochondrial DNA in there. Perhaps some people from this morning might disagree with that, but you should be aware of its limitations before you start using it. And of course, you want to be, if you are going to use it, then you want to obviously again have the best protocols in place, the best eggs and the best embryos. You're not going to be able to do mitochondrial replacement stuff like that with very poor eggs. And thank you. That's the end. Thanks very much.
Thank you very much for an extremely meaningful and interesting presentation.